really excited today to have a division speaker starting us out, and then our last visiting professor of the year, Dr. Tolwani. So we will start with Dr. Nicolae Leca.
Thank you, Dr. Butler. My pleasure to present today, and thank you for the opportunity to be an opening act for our visiting professor today. I mean, full disclosure, I did Google last night famous opening acts, and the best I came up with was the Who opening for The Clash in 1982. All right, so these are my disclosures. I serve as the primary principal investigator for multiple sponsor trials, and also Natera is the provider for our main genetic test that we use in pre-transplant and living donor clinic, which I will be referring to in this talk. So let's start to frame the importance of testing, genetic testing for living donors. Well, it's because there is a very clear evidence that there is an increased risk of end-stage renal disease for donors that are biologically related to their recipients. This is pivotal data in living donor end-stage renal disease rates. The first study comes from the UNOS analysis and shows practically a twofold increase in risk for development end-stage renal disease for first-degree relatives, parents or siblings. That risk increases all the way to 20-fold for identical twins. Yet analysis from Johns Hopkins, the same OPTN database, that's another pivotal important database that shows, again, a doubling of risk for biological related versus unrelated donors, with an incidence of 34 versus 15 per 10,000 at 15 years of follow-up. The third study is from Norway, in which they have a public health system, and they compared living donor outcomes with lookalikes, healthy controls, if you want, and they've shown a 11-fold increase in the risk of end-stage renal disease for living donors. Important to note is that event rates are actually quite low. Like in Norway, there are only 9 end-stage renal disease events, and they all happen in the biologically related donors. There have been others that have suggested that if we eliminate the related living donors, we actually eliminate 90% of end-stage renal disease events in the donors. However, it's important to realize that being biologically related also doesn't mean all genetics. Then it's possible that other shared environmental factors may be contributing to these differences. What are the current policies and guidelines in relation to living donor testing? Very loose. So for kidney, it only requires a personal history of significant medical conditions, which include genetic renal disease. For liver, newer policy, living donors actually spell out that a program must develop and follow a written protocol for testing for genetic diseases. KDIGO guidelines does recommend that donors should be asked about family history of kidney disease, and when the intended recipient is biologically related to the donor, all efforts should be made to characterize that disease whenever possible. Let's us frame some more with a clinical case. This is a case from our clinic. It's a 38-year-old man at the time of the transplant, at history of hypertension and gout. His GFR was 10. He was not on dialysis. Family history was positive for diabetes, but negative for chronic kidney disease. He actually underwent a kidney biopsy 7 years prior to transplant at presentation with kidney disease that showed focal segmental and focal global glomerulosclerosis. Of note, he was subnephrotic at presentation. And because of the unclear cause of the kidney disease, he actually underwent renal genetic panel next generation sequencing that was reportedly negative. You see in the insert a representative picture from his electron microscopy showing you mainly well-preserved podocyte food processes here, so suggesting maybe a secondary etiology for his FSGS. The donor was his sister, 31-year-old, 2 haplotype match, no medical issues. Surgery is only notable for C-section. She had normal labs, normal exam, normal CAT scan. She underwent an uneventful lab donor nephrectomy, and our surgeons practice that we encourage, and we would love everyone to do it, but in this case, elected to do a pre-implantation biopsy. Soon I will be showing you a representative pathognomonic picture of an electron microscopy from this slide. I will argue with you that we maybe have already enough information to at least have a very good assumption, logical assumption of what that picture is going to show, but I'm not going to ask you yet. But think about it, and as we think about the next slides, let's see if we can come up with the answer. All right, so how frequent are genetic diseases in CKD population? This is a recent study that looked at a non-biased cohort of over 1,600 patients and showed a result that's actually similar to other cohorts that have evaluated this relationship. At approximately 20% of patients do carry a genetic diagnosis. In this study, they utilized rhinocyte in particular, and they found genetic findings in 21% of patients encompassing variants in 54 genes. As a result of the testing, 49 patients underwent receive a new or revised diagnosis. You see the 6 most common genes that were identified as variants. No surprises there: PKD1, PKD2, APOL1 risk variants, and then the 3 collagen 4A subtypes. To the right, you see the prevalence of genetic changes when patients were grouped by phenotypes, for example. No surprise in cystic nephropathy, very high association. Also syndromic type of presentation like hematuria, very, very high association with genetic causes. But I want to draw your attention that even patients with diabetes, 10% had genetic causes, and also 20% for those with CKD of unknown etiology, which really suggests that we should be using this genetic test much more frequently in our clinics. How different are we? Well, the haploid human genome has 3 billion the haploid human genome has 3 billion base pairs. Each of us carries approximately 3 million variants, and by variants we mean either single nucleotide variants, insertions or deletions of genetic material, or copy number variants. And approximately 5,000 of these variants are actually in coding regions that are for genes that are associated with monogenic diseases. The American College of Medical Genetics and Genomics do categorize this based on the potential association with the phenotype as benign, likely benign, variants of unclear significance, likely pathogenic, or pathogenic. So who should test as far as living donors? Very important, paramount importance, family history. That's very, very important. So patients that have someone that has a known genetic disease, suspected genetic disease, usually when there are multiple members of the family that are affected, or younger presentation, multi-system presentation as well, very, very important clues for a genetic cause. But also when there is unknown etiology of chronic kidney disease, as I've shown you, 1 in 5 will potentially have a genetic cause. But family history is not always available. And some consideration for direct testing may be given. Our program does test younger donors, even when unrelated to their recipients under the age of 35. That's our effort to try to add some more objective data to already unclear phenotype when you evaluate someone that's very young in relation to future risk of disease. One more time, what are the genetic testing approaches in living donors? Test the recipient, if related, or the affected family member first, then identify if there's a association, variant association, and then target test the living donor. This is the best approach. This avoids potentially finding things that you don't know what they represent. Again, not always possible. You can potentially test living donors directly with the renal gene panel. We do that with rhinocyte in our program. So again, trying to somewhat minimize the potential for false positives or things that we do not understand. Also, genetic counseling is very, very important. So this counseling should happen before the test, in which the potential for false positives and false negatives will be discussed, the potential implications of a positive result. I think that's very, very important for the donors to understand, as well as post-test counseling, in which explanation of results is very important, and then potential follow-up, those that may need to be referred for future steps or specialized care. In our program, we have developed a relationship with Brandon and the renal genetics clinic at Harborview. Has been of very substantial importance for our program to be able to help us with making sense of some of the results, as well as potentially following up on patients that are identified and affected. The Congress in 2008 has passed the Genetic Information Non-Discrimination Act that prohibits discrimination on the basis of genetic information in respect to health insurance and employment. The fine print says that the life and disability insurance is not covered. Also, small businesses with less than 15 employees, as well as those that are employed by a military or receiving VA benefits, are not covered by this act. So, what are the testing options for living donors? Next generation sequencing is the workhorse of genetic testing these days. It's a misnomer. It should be current generation sequencing. It's really the mainstream. And the types of next generation sequencing, again, a specialized gene panels like the renal gene panel that we use. The advantages are obviously a very addresses a defined phenotype, has a very high diagnostic yield. The cost and the files that are generated are much smaller. The disadvantages are that updates are needed, so someone has to actually go through all those and update the USs, and as the category changes for the importance of those variants, it has less sensitivity, misses outside of the gene panel, and a negative, if you want, for all the next generation sequencing panels is that they are not great for detecting copy number variants, as well as regions that are very enriched in C, G, may be missed. Whole exome sequencing, again, this is going to be recommended for patients in which there is a high suspicion for chronic kidney disease of unknown etiology, identifies variants in coding regions, and as a disadvantages, obviously, larger files, potential secondary findings, more VUSs, and more false positives. And then the most comprehensive, obviously, is the whole genome sequencing, in which you still have a high index of suspicion, and exome sequencing has not revealed results. So you're now using a pangenomic approach, obviously more expensive, much larger data files, and more challenges to interpret the results. There are other additional testing options when you look just for a single gene with a Sanger sequencing technique. That's important. Like, for example, you want to look just for APOL1 or for just the abnormality or variant in the GAL gene. That's for Fabry's. Fast turnaround, inexpensive, very good for conforming abnormalities, for example, that you identified by next generation sequencing. There are other modalities. I'll let you read those. Not really used in common practice, but important to know. Those are mainly for detecting issues with copy number variants, and there are other more specialized techniques. These are important for example, changes in MUC1 gene, which is associated with autosomal dominant tubulointerstitial disorder, or certain mutations in complement genes are very difficult to diagnose with NGS techniques. This slide shows you some of the databases that are very commonly used in practice. ClinVar is a public database for identified genetic variants and association with disease. I mean, I strongly encourage you, next time you get the genetic results, to get that abstract and plug it in one of these databases. It's actually amazing how much information is there. There are links with papers, there are links with reports. It's actually quite comprehensive. NOM-AD, another public database with full results from multiple reports. The highlight here is that it can provide global allele frequencies. PingGen is another NIH resource for precision research. And then there are other databases for educational purposes, the gene reviews and databases, which I, again, recommend for getting to the next level and understanding of this finding. So let's take in now more detail some of the most common genetic association with renal disease. Obviously, polycystic kidney disease, approximately 10% of end-stage renal disease patients, further enriched in transplantation. You don't need genetic testing always for polycystic kidney disease, definitely for someone that presents with a very clear syndrome, and vice versa for donors. If there's negative imaging criteria for someone that's over the age of 40, that practically rules out PKD without a genetic test. What do you do with younger patients? That's where genetics may become more important. PKD1 and PKD2 are not the only genes associated with cysts in the kidney. As a matter of fact, the ciliopathy gene panel includes 85 genes in the differential diagnosis. Also important to know that the next generation sequencing misses 7% of the PKD mutations, and sometimes you may need to consider additional testing if there is a high index of suspicion. ASN, Alport spectrum nephropathy. So again, the collagen 4A genes 3, 4, and 5, they account for 1/3 of CKD of unknown etiology. There's also a very substantial association with focal segmental glomerulosclerosis. Up to 25% of patients may actually have variants in these genes. Transmission is autosomal dominant in 5% of the cases, recessive 15%. These are usually 3 and 4s, and the vast majority are X-linked, the A5 type in 80% of the cases. The clinical spectrum of Alport is quite large. It can be completely benign. It can be benign hematuria, where the thin basement membrane disease, or full Alport syndrome, in which you have association with hearing loss and other findings. In general, if you find a shared variant in these genes between the donor and recipient, is recommended to not consider that donor for donation. Also important to know the false positives. The Alport spectrum is very common in the population. 1 in 500, 1 in 1,000 patients may fit in this syndrome. But when you look at variants in these genes are even more common, like 1 in 63 for Hispanic population, and 1 in 106 for like the general population. Atypical hemolytic uremic syndrome, genetic variants account for 50 to 60% of the cases. Again, there's a multi-hit hypothesis. These genetic changes are not always sufficient for the syndrome to happen. Most of these genes have an autosomal dominant transmission, but recessive is also possible. Again, it's recommended to exclude living donors that share a mutation with their affected recipients. There's also debate what to do when you don't find the genetic test. So you have an affected recipient that has a very clear atypical HUS, and it's possible that we just don't know the mutation, or it's not been yet understood. So there's been suggestion that potentially avoiding using a living related donor in those cases. Autosomal dominant suprainterstitial kidney disease, 6 genes make this panel. Again, most commonly uromodulin, but MUC can also be part of this. Important to realize here, this is a disease that's very hard to diagnose. Even the biopsies may be completely non-specific. The clinical presentation is also very non-specific. CKD, non-proteinuric CKD, gout may be associated. And keep in mind that MUC does require much more specialized genetic testing. So if there's an index of suspicion, you may actually have to ask for that gene in particular. Fabry's disease, so GLA gene is associated. Very, very high number of variants have been described, over 1,000. It's transmitted X-linked and leads to deficiency in alpha galactosidase A enzymatic activity leads to glycosphingolipid accumulation, which look like the zebra bodies as we see them in the electron microscopies, usually in the podocytes and endothelial cells. For affected patients with Fabry's, for men, diagnosis is usually made by testing enzymatic activity in the blood, and a normal enzymatic activity practically rules out the disease. For females, that's not sufficient. So normal enzymatic activity does not rule out the disease. As a matter of fact, even then, 70% of females may actually develop symptoms related to Fabry's due to random X chromosome inactivation. Important to keep in mind here the generational skipping, which is obviously valid for any X-linked disease. So back to our case presentation. So again, I've shown you some data in the recipient that maybe some red herrings there, maybe kind of leaning you towards some tubulointerstitial disease, right, with CKD and gout and non-proteinuric. I mean, it was proteinuric, but not non-nephrotic, I should say. Yeah, I told you that this is going to be a pathognomonic electron microscopy picture. So, any takers? All right. Yeah. Exactly. Well, let me tell you how Brendan came up with that. So really, first of all, if we take this out of context, what will be the most common finding here? A normal biopsy, right? 90%, 95% of the cases, this will be a normal biopsy. The other is going to be what's going to be the next abnormal finding that we see in out of context with the IgA. Again, probably, I mean, you can argue some familiar IgA, but again, you're not going to see a pathognomonic EM finding here. So what else? Well, FSGS, right? Unlikely. Again, no abnormalities found in the recipient, and she's obviously non-proteinuric. It will be, yeah, I could potentially show you a thin basement membrane, but yeah, that will not be that great. Tubular disorders out of the question. It's an electron microscopy picture, so you're practically left with zebras, and that's right. There you go. So those are the zebra bodies, and yeah, and what again, this is a case that it came to us very, very surprising. So I called a friend, I called Brandon, and he did some more testing. So it turns out that this patient had a VUS in GLA gene, which led to a missense mutation. Glycine was replaced by serine. There've been no reports of this mutation before. There were some reports in which aspart was replacing glycine, and that led to in vitro data showing only 25% of wild type enzymatic activity. This was ultimately reclassified as a class 3 mutation, in which there are 4 classes and 1 is the worst. And the patient also underwent enzymatic activity that showed that urinary and plasma GL3s were normal, but the plasma lysosomal GL3 was elevated. To date, this donor is doing well. There's no evidence of proteinuria. Most recent creatinine was 0.8. And Brendan, I believe you've seen her, and probably maybe at some point she will come back. ApoL1, different here. This is not a monogenic disease, but rather at-risk allele. So it's not necessary nor sufficient for the disease to happen. In this case, end-stage renal disease. Second hit is required. So the association with hypertension, for example, leads to a 7 to 10-fold increase in the risk of end-stage renal disease. Association with HIV, 30 to 90-fold. Increase in that association. The high risk alleles G1 and G2, and you need to be either homozygous or complex heterozygous for this genes for the risk to actually happen. And there is data already that high risk variant donors have a lower pre as well as post donation EGFR. And overall, the ApoL1 risk variants double the risk of end-stage renal disease. That's similar to the impact of obesity and sickle cell trait. Again, there are debates and ongoing different approaches to how to approach this risk stratification there are variants in practice, and in general, it is recommended that shared decision-making should be in relation to testing and acceptability for donation. In the interest of time, I'll skip these two slides, which practically show models of renal genetic clinics implementation, one in Europe, one at Columbia University, showing that they are cost effective and they lead to changes in practice. We already have our renal genetic clinic, so not that's important for our program. So in conclusion, I think it's extremely important that we upstream characterize CKD whenever possible, and that will be essential for living donor testing implications. I think we are at a time where routine CKD clinical should encompass routine genetic testing. That will allow us to generate enough data to hopefully in the future transcend from monogenic diseases to maybe be able to calculate polygenic risk score for association with end-stage renal disease and so forth. And then living donor genetic testing is in its infancy and does require development of robust institutional as well as national policies and guidelines, as well as collaborations with specialized genetic clinics for counseling as well as for follow-up finding. I want to acknowledge again our renal genetic clinic at UW, Brendan Shannon and Sirisak Champrasar have been wonderful for our program and great resource. Renasite, yeah, I mean, practically genetic testing for us has been a black box before, you know, whom, where, how, who pays for it. All those questions were made easy, and this is something that we now routinely use. And also, I want to recognize the work that's been done by the ASD living donor community of practice, which have been very active in this arena. So thank you for your attention. I'll take some questions. Yes, Kim. I mean, in all fairness, we've used Renasite just because it's been free for us for the longest time. We now are contracted with them, but it's been easy to do. It's a 385 gene, so it's not. I don't think it includes everything. I think there are other panels. I think the future will be to be more specific in the testing whenever possible. But obviously, you know, when you're looking at someone with CKD or unknown etiology, it cannot be. For us, yes, maybe if we are worried about the ciliopathy, test with a ciliopathy gene panel or complement panel or something that's much as focused on the disease of the recipient or affected family members as possible from a living donor perspective. But I think from a kind of more agnostic perspective of trying to characterize the genetic association, I think probably more is better.